Everyone, how are you? My name is Garang, and today we'll be talking about respiratory distress in the children. When we define the term respiratory distress, it means the effort of breathing. When the effort of breathing increase, there will be some signs that indicate the child has respiratory distress or the adult has respiratory distress. Now let's talk about respiratory distress in children. So in the infants or the pediatric departments, the respiratory distress is really very common, especially in NICU or neonates. In the neonates wards, you can find children with respiratory distress, and there are a lot of clinical manifestations, of course. And some of these clinical manifestations, like grunting, breathing very fast, which we call it tachypnea, tachycardia, these cyanosis or discolorations, maybe central or peripheral cyanosis, are very common. Now, what is the primary cause of respiratory distress? We can divide them into two. There's respiratory distress and respiratory distress syndrome. These are two completely different. And based on that, the causes are also different. So, what we'll be talking now about is respiratory distress, not the syndrome. The respiratory distress is a manifestation which is non-specific, can be caused by any medical condition. It can be the intrapulmonary cause, or it can be extrapulmonary cause. So let's talk about intrapulmonary cause first. Any disease that leads to obstruction of the airway, or any disease that reduces the compliance of the lung itself, can cause respiratory distress. Giving example, if we're talking about right heart failure, we know right heart failure is the main cause of the blood stagnant in the venous system. If the blood is stagnant in the venous system, the blood from the systemic arterioles will stand, and then the blood in the right side of the heart, the left side of the heart will stop, and therefore the left side of the heart will not receive the more blood coming from the pulmonary arteries, veins, So if we cannot do so, then the blood will be stagnant, will stop within the pulmonary circulation and in the lung. That will lead to the leakage of the blood, leakage of the protein, plasma proteins, and that will lead to edema. And the edema will occupy the place within the lung. There is not enough air to go in, or there is not enough dilations of the lung. That will lead to something called edematous pulmonary disease. And then also, if there's infection, for example, pneumonia, there will be inflammations of the lung, and inflammation of the lung will lead to reductions of this space. Now, that's one side. The other side, they talked about the wall, chest wall. If there's a problem with chest wall, like if there's trauma or it's neuro or some kind of thing, or diaphragm is going upwards, and this will cause another problem. And this problem is there's not enough space. The lung's fine, the air is coming in fine, but there's not enough space for the lung to span. So if the lung cannot span, that means there's not enough air going in, there's not enough oxygenation, there's no circulation of oxygen, and as a compensatory mechanism, the body will start to increase the respiratory rate, and it will show usage of accessory muscles like sternocleidomastoid muscle, abdominal muscles, and like elevator scapulae and like skeletal muscles. They will all be contracted to assist in the process of breathing in anathem to solve the problems of blockage of the air. Now, that is on the other hand. Again, there are some causes which are exterior or extrapulmonary causes of respiratory distress. Now, it might be due to the problem in the left side of the heart. If the left side of the heart fail, then, or pericarditis, commonly if there's pericarditis, there will be restriction or constrictive or restrictive pericarditis, will cause the heart not to receive enough blood. It's our blood that comes from the left side of the heart, comes from the lung. So stagnant the blood in the lung will lead into occupation. So the space within the lung, there's not enough air to be exchanged, there's not enough air to be received, and that also will lead into tachypnea. Now let's talk about manifestation. The manifestations of these conditions are seen like breathing, which is an effort to keep the air in the lung, in the alveoli, so that alveoli will not collapse at the end expiratory, and we hear it always in the end expiratory. If there are obstructions in the upper level of the bronchotracheal system or trachobronchial system, if there is an upper, we are more likely to hear stridor, which is like a whistling sound. And also, the inspiration is longer than expiration because the air is going slowly inside, but it may come to the force of contraction. So, diaphragm relaxation and moving upwards, and the contraction moving outwards, and the contraction of intercostal muscles, and then the air will be expelled outside. If that is not happening, then the both ways should be slow in case of obstruction in the mid-lung. But when most of the instructions are down below in the obstructive, the lung disease is down below or in the alveoli, the most things we hear are wheezings, right? There's another one also like sweating due to palpitation that we see also as a manifestation. The cardiac, we know it's CVS, cardiovascular system that cause it. There will be also flaring, nasal flaring, and nasal flaring is really, really important in determining the seriousness of the respiratory distress. So when there is flaring, that most likely there is a very, very exaggerated stress. And then we have also some other symptoms, such like we mentioned wheezing, stridor, and palpitations is one of them, and many of them. So we have to understand the mechanism first. Then we will know how to explain this, why this mechanism are taking place. So there are two things: obstructive pulmonary disease and restrictive pulmonary disease. If we talk obstructive, there is no good flow of the air to the lung. So if we talked about restrictive impairment, so then restrictive impairment means there is air, the airways are normal, the air can go in, but there is no good space for the lung to span. If that's happening, then we have to understand there's a problem with the space, not with the airway, not with another system. Okay? That way you can categorize them into two main categories: obstructive and restrictive impairments. Thank you very much for watching. Once again, my name is Garang. I'm C2 Medical Student. May God bless you.